everyone, I'm John Lynn, the founder and chief editor at Healthcare IT Today. We're excited to bring you another in our series of interviews with top leaders in health IT. And our guest today is Sachin Gupta. He's founder and CEO at IKS Health. Welcome, Sachin.
Thank you so much, John. Great to be with you.
Yeah, excited for this discussion. It's been an exciting time at IKS Health. But for those that don't know about you, tell us about IKS Health and also the fact that you went public and how your company is really growing globally.
Thank you. Yes, the genesis, John, of IKS Health was in the realization that there are perhaps quite a few things that are making our healthcare system in the US unsustainable, and that it needed to undergo a significant transformation to achieve sustainability. And we built our company on the fundamental thesis of one transformation, which is what I call the transformation of healthcare from a reactive hospital centric care delivery system to a proactive, physician led, and patient centric care delivery system in which physicians reassume their role of not just being caregivers, but being co navigators of care for patients in their care journeys, helping them make the right decisions. And even as we believed in that, especially in a world where a large part of the cost of care is driven by chronic lifestyle disease, it became evident to us that the very physicians that are going to become the new fulcrum of care delivery as we move to a more sustainable care delivery system are the ones that are actually straddled with some of the biggest challenges. The reality is that cost of operations are escalating faster than their revenues. They have to take care of larger and larger patient panels in a world where their time is actually getting highly limited. National statistic is that physicians are spending nearly 50% of their time on non-patient care, non-value added tasks. And in a world where they have to see more and more patients, that just doesn't make sense. And so in order to bring sustainability and viability to this most important point of care, we've created a simple principle, which was what we call the redefinition of the core versus chore equation within the physician's task continuum. And our simple thinking was the smart physician enterprises will realize that they should focus more and more energy on their core task, which is the task of taking care of patients. And a lot of these other chores that distract them should be delegated to some entity, some platform that can do these chores better, cheaper, faster at scale. And 17 years ago, we set on a journey to essentially create such a platform to delegate all these chore tasks, to give physicians back, first and not foremost, the time to care, second, the freedom to care, and third, equally importantly, the economics. And we built this platform in a way where not only is it highly accretive in terms of the physician and their care team's time, but it is very, very financially accretive to the physician enterprise, where we're able to free up as much as somewhere between 700 to 1,000 basis points as a percentage of the physician's revenue back into their P&L as a result of delegating these chores by doing them better, cheaper, faster at scale. So that was a journey that we embarked on 17 years ago. And 17 years later, we're now servicing about 150,000 physicians across the country, across 500 large group settings. These are almost equally stratified across large health system owned groups, large private equity owned single specialty roll ups, and large private equity owned or publicly traded multi specialty groups that are led by primary care and geared to succeed in risk constructs. As we did that, we became an enterprise with about 13,000 employees of our own. We employ about nearly 1,500 clinicians ourselves. And as we built this model where that brings, hopefully enables sustainability to deliver better, safer, more efficient care for physicians and their patients, we also did it in a way where we were able to build good unit economics. And that emboldened us to then take the company public last year, which obviously was an important milestone in the journey of what we're trying to create. So yes, we're excited about what has happened over the last 18 years, but to be honest, even more excited about what lies ahead, because we still think we're babies in this journey of building out this care enablement platform.
Yeah, it's true. There's still so much potential to solve the problems that you described. It's no wonder that doctors love you, since you're focused on making their lives more efficient and impacting the bottom line as well, which most organizations like as well. Talk to me more about what is IKS doing today that is new or different, and I'd love to hear more examples and ideas about how IKS is helping with healthcare efficiencies kind of across the board, as you described?
Yeah, that's a great question. One of the things that we discovered is that the physician market in the US is about a $1.5 trillion market, believe it or not. And there's 900,000 odd physicians across the country that drive that $1.5 trillion. And when we did our analysis of what are all these chore tasks that physicians get stuck with, we actually realized there's as many as about 16 different tasks that physicians get stuck with. And the way we discern these tasks, we did a simple analysis. We basically applied an equation that said, if there's a task that need not be done by the physician or the care team, let it not be, it might be a chore. And if there's a task that need not be done in the clinic physically, let it not be, it might be a chore. When we applied those two simple principles, a whole bunch of tasks became candidates for chores that our platform could delegate. Then we said, which of these chores can we do better, cheaper, faster at scale, leveraging the two things that we're good at. And the two things that we came up with that we would combine to do these tasks better, cheaper, faster was one, I'm a computer science engineer by training. So my first instinct was let's write technology to totally eliminate these tasks. But because I've also learned that one of the biggest mistakes we engineers have done in healthcare is we've in fact somehow rolled out technology that has made providers often less productive versus making them more productive. And in order to eliminate that risk, we said this time we will write technology that is pragmatic, that tries to eliminate tasks. But in order to do that, even as advanced as technologies become now with Gen AI, cognitive RPA, NLP, all the good stuff, it's clear to me that often this technology still needs a human in the loop for the last mile to complete the task and complete it safely. And so we said we would combine the proprietary technology that we will write with pragmatic human capital, global human capital, because human capital needs to scale. And when we applied those lenses, what came out was this 16 odd chores that became the features of our care enablement platform. And we basically mapped out these 16 chores all the way of the patient's journey with the physician enterprise, all the way from tasks that could be delegated prior to the patient's visit with the physician enterprise, in and around the patient's visit with the physician enterprise, immediately after the patient's visit with the physician enterprise, and then in between successive visits, because the patient-physician relationship is a continuum. And our simple principle was for each of these tasks, either they have to be clinically accretive and free up time for the physician, and or they have to be financially accretive, freeing up more financial resources on the P&L. So several examples of these would be tasks like clinical documentation, which I'm sure everybody's heard of. The 2 hours a day that physicians often end up spending on clinical documentation, the time they end up spending on coding, which, obviously physicians are not meant to be experts on coding, yet they're left with this unenviable task of coding or the claims before they make it to a claim. Or think of things like another big pain physicians are struggling with is inbox. The physician's
Yeah.
EHR inbox has become a huge burden. Then national statistic is they're spending 45 to 60 minutes clearing the backlog on their inbox, even though more than nearly 70% of the messages in the inbox need not even deserve the attention of the physician themselves and can be managed by other players in the care team. Or another big burden that physicians and their care teams and even administrative staff struggle with is prior authorizations. They are the biggest causes of denials or the biggest cause of what I call non-reimbursed care that is often delivered. So there's all of these things like, same day no show, same day cancellations for patients today are as high as 15% nationally. Think about it, in a world where we're trying to improve access, and access is a huge challenge. If you have 15% same day cancellations, what if there was a scheduling optimization algorithm that actually improved patients' propensity to show and actually helped schedule in a way that schedules could be utilized better? The ever lasting challenge of revenue cycle management. So there's all of these 16 features that we discovered, and our simple thinking was, in a world where $1.5 trillion is the physician reimbursement, we analyzed that actually nearly 15% of that $1.5 trillion, believe it or not, John, is being spent on these chore tasks. That's
Yeah.
about $225 billion being spent on these tasks that have not much to do with patient care. And when such a large TAM or total addressable market exists, it became clearer to us that what will happen is a lot of companies get created that are focused on just one or two or three of these features. like clinical documentation companies or medical coding companies or prior authorization companies or revenue cycle management companies, or if you look at the value-based care related tasks, just tasks, companies that focus on RAF optimization, HCC coding. But our thinking clearly was that over a period of time, as the market matures, providers will realize they can't be in the business of buying 10, 12, 14 different point solutions, integrating them, holding the bag of creating value from them. And so our vision was, let's build one platform that can truly delegate all these tasks as a continuum and relieve the provider organizations of this burden. And eventually, people will realize that that might be the solution that enables them to focus on their core and improve patient care while improving the economics of the practice. And yet, because the buying behavior of large provider organizations isn't quite at the platform level yet, our execution strategy is predicated on this approach of we want to be number one or two or three in each of the features, even as perhaps we're the only company in the world building the entire breadth of the platform, because that allows us to navigate the more pervasive buying behavior today, which is point solutions, and yet work with the early innovators that get the platform thesis and are working with us on that approach. So that's sort of been the uniqueness of the manner in which we've tried to approach this industry. It makes execution harder, to be perfectly honest, John, because I think it's a bit easier to be just a clinical documentation company or just a prior auth company.
Sure.
It's probably even more capital intensive to do what we're trying to do, but we firmly and passionately believe that the right answer for provider organizations in the end is going to be to have an integrated solution that delegates all of this burden as a whole. So, and that's what we are in the passionate pursuit of.
Well, it's a classic tech cycle, right? Of best of breed versus all in one. But if there's not an all-in-one platform, we have to do best of breed until there's an all-in-one that comes around that is good enough in all the areas that we can do. We see that over and over. We're coming out of the big conference season, HIMSS, Vive, all those conferences. Lots of big announcements. You had a recent product launch as well. Talk to me about the value you expect it to provide healthcare organizations.
Yeah, so the launch that we did at Vive was really around our entire range of clinical documentation suite that we have created, which we call the Scribble Suite, which essentially is an ode to the physician's handwriting, the name in the Scribble.
Sure.
But the idea is that over the years, as we built out the various versions or the variants of our clinical documentation product, all the way from transcription to human-assisted scribing to a totally ambient Gen AI technology called Scribble Now, which is the one that we launched at Vive. What we've realized is that there is, from our experience, not a one-size-fits-all solution for large physician enterprises. Whether they're hospital-employed groups or independent groups or private equity-owned groups, typically there is a very wide demographic of physician users, different ages, different savviness with technology. And we find that different types of physician personas respond better to a different type of clinical documentation solution. Some physicians are more than happy with a fully autonomous ambient technology generated note enabled by Gen AI, which is our Scribble Now product, and they don't mind being the editors of that note to make it work for the type of encounters they have. Other physicians are much more happier with the note that is produced by the ambient technology, but then is now supervised and edited by a human that monitors it and eliminates things like hallucinations and biases in it. There's other physicians that we've seen that are happy with not just the note that has been eliminated, that has been cleaned off from a biases and hallucinations perspective, but they even prefer a human to then make the note much more coding friendly, where it's charted on a problem basis. It qualifies for meet criteria if it's a value-based care patient that they're talking about, and then perhaps furthers it to where if we are already creating note that is appropriately structured from a coding perspective, should we even bundle that clinical documentation process with the actual coding? So we've created about 5 variants of our clinical documentation product that incorporates all of these variations, including, by the way, a pure transcription product for settings where physicians still need to dictate and a transcription is an answer, like the ologies, right? A radiology or a pathology, where there isn't really a physician patient encounter that a machine can listen into and create the document from. And I think what we've in the process done is create the most comprehensive range of clinical documentation options for physicians that meet individual physicians within a physician enterprise where they are in their journey to adopting clinical documentation. In fact, one of our other variants that we are working on is a scenario where, for even an individual physician, they might choose different variants of Scribble for different types of encounters. There could be some very easy, straightforward encounters where they choose just the ambient variant, Scribble Now, but there could be some highly complex encounters where there is detailed diagnosis for which they might choose a version called Scribble Pro that not only has human supervision but actually has a clinician supervising the note and editing it to make it coding friendly, and then eventually assigning codes to it as well. So I think that's what we're really excited about, is a comprehensive range that meets physicians where they are in the journey of effectively adopting clinical documentation and actually creating the ROI from it, which really lies in the fact that it frees up time, it allows them to perhaps see more patients during the day, and also allows optimization of RVUs per visit based on the most appropriate and comprehensive document that needs to be generated from the account.
Yeah, I mean, I think that's one of the most comprehensive AI medical scribe type of solutions that I've seen. And it's fascinating to think it on a per encounter basis. That's a different way of thinking about the solution. Talk to me more about your care enablement platform. What is it? Why is it important? How does it work?
Yeah, the care enablement platform, John, like I was sort of saying earlier, is built really on the thesis of the value of the whole is much greater than the sum of the individual parts. And I think it probably is the only comprehensive platform that delegates all of these 16 chore tasks from a physician or a clinic's workflow. So that's one distinguishing factor. The other distinguishing factor also, John, is the fact that one of my observations in healthcare IT over the last 2 decades really is that there exists almost a fundamental misalignment between the value healthcare IT often promises to providers and the value providers are able to derive from healthcare IT. And in order to solve for that misalignment, what we're doing is we're, for customers that are early adopters of this platform, we are actually starting to underwrite some of the financial value creation from the platform for the providers. So they don't buy the solution with the promise of the value that it will create, but with the underwriting of the value that it would create. And actually, one of our objectives of going public also was to create a large enough balance sheet that allows us to underwrite this solution effectively for providers. So I think the uniqueness of the platform lies at the cross section of, or at the confluence of both the breadth of the platform and its comprehensiveness, and two, how we are financially aligning the value proposition in a way where providers are guaranteed to be able to derive the promised financial value from the platform. Now, obviously, as a result of that, it takes a little bit of effort upfront to do a little bit more analysis to make sure that we're underwriting a realistic thesis. But now, once providers have that thesis co-analyzed with us, they know that what they're buying is going to deliver at least the financial promise that it is supposed to. And we're finding that a lot of large healthcare system executives, large CEOs of large groups are responding very interestingly and favorably to that construct.
Well, I mean, we're embracing value-based care in healthcare. Shouldn't we embrace value-based care, value-based IT, I guess, is the
Oh,
how you would
that's
look
an
at
interesting
it.
term you're coming there. I might borrow that term from you. Value-based healthcare IT. That might be interesting.
It's close, right? So talk to me about AI. It's an important topic. We're seeing across all of it. How is IKS, using AI maybe differently than other competitors? And what do you see as some of the benefits of AI? And also, you obviously have a unique position because you're balancing AI and humans. I'd love to hear kind of IKS's perspective on AI and the benefits and involving humans as well.
Yeah, look, I think we're passionate believers in AI, and we believe that that AI is not an evolution, but it's clearly a revolution. And first of all, I feel like one of the biggest values of AI is going to be that it brings a different level of scalability to our solutions. Because any solution that is predominantly dependent on humans to scale comes up with its own limitations. And so we're passionate believers. We're actually within our care enablement platform, which has 16 features, we're working on at least 7 or 8 use cases that in which AI powers those features. Just like we rolled out Scribble now, we're working on things like fully autonomous coding. In fact, we already have it working really well for 2 specialties, and we're rapidly expanding it across specialties. We've got AI-enabled solutions on prior authorization. And my whole belief on AI is that you go from human-led and tech in the loop to AI-led and human in the loop, and eventually you go to a fully autonomous solution. And I feel like that is a maturity curve that needs to be achieved over a period of time. And because as powerful as AI is, and especially Gen AI is, it does come with its sets of biases and hallucinations. And we're talking about healthcare here. Our whole thinking is AI has to be partnered with human in the loop so that physician users, administrative users start trusting the AI meaningfully. And over a period of time, as our human overlay starts to become redundant because the AI has become just so mature that it does not need that audit and edit over a period of time, at that point, those solutions will become autonomous. So we're constantly on this journey of human-led tech in the loop, tech-led human in the loop powered by AI, to fully autonomous powered by AI in all of our features. And that's sort of the journey that we are deliberately on. Our other thinking also, John, is that in this process, by having the humans in the loop, we will create what I call these deep trust pipes with these physicians, right?
Mm.
Because I think when you have a community that is highly stressed, the first thing, if you want to engage them, is to first help them by doing these tasks safely and giving them time back through the combination of AI and human in the loop. We are actually creating a help scenario. And in the process, I call it, we're creating a trust pipe with these physicians. Once they start trusting us because we're safely delegating these tasks and giving them time, then we can actually start to insert insight into these trust pipes that actually help them move along the journey of actually providing even more safer care, better care, evidence-based care. Today, I think in the past, we've always had solutions that are evidence-based solutions that can provide physicians insight into how best they can care for their patients. But the reality is physicians either don't have trust in them or they don't have time for them. We are first creating time, and in the process creating trust, and then we can leverage the AI to actually insert snippets of advice that the physician would have year and time for that can actually improve the quality of care.
Mm. I might have to steal that trust pipe one from you, but that's a good one. And I've been saying that, the AI medical scribe is going to become the interface of the doctor. And once that's the interface, then it opens up all sorts of new opportunities, which I think is what you just described, but layered with trust. That's a fascinating concept. As you kind of look forward to the future of AI in healthcare and even technology in general in healthcare, what do you see and what do you believe is going to happen in 5 years or even longer from now?
Yeah, it's a fascinating question, John. I'm hoping that for different parts of our patient population, AI might have actually different impacts. When you think of younger, healthier populations, I, I can imagine a world where the AI eliminates to a large extent the need for a regular interface with a physician. Uh, for older, sicker populations with chronic diseases, multiple comorbidities, uh, the AI becomes more and more of a sensor to early problem identification, and obviously does things like risk stratification seamlessly so that physicians can then truly move into a proactive care model, preempt episodes of care that lead to things like hospitalizations and rehospitalizations, and actually truly improve the quality of life of patients proactively, which, as you know, naturally reduces cost of care. So I actually think over a period of time, AI applied differentially to different demographics of our patient populations can actually help us solve for this holy grail of what I call cost, quality, access, which are the three biggest problems we have in healthcare. Our cost of healthcare is too high, quality of healthcare is deteriorating because physicians and their care teams just don't have enough time and are overworked. And then, of course, access to care is a challenge because they have to take care of so many more patients. So I think AI has a real potential to revolutionize healthcare in a pragmatic manner, done right over a period of time.
Yeah. It's interesting that you say that. I was at an AI conference recently, and they said, the small town in India that doesn't have a local doctor is going to get the AI solution first. It's kind of a fundamentally interesting thing when it comes to access. We have challenges in modern society. We need the doctor there, and there's trust and liability and all sorts of things. But yeah, we're going to see such an evolution across so many different areas. And I think it's going to be international, which obviously IKS Health has a big international presence as well. So Sachin, I appreciate you taking time to talk with me and share these insights and perspectives. I love the breadth that you're going to create kind of a full AI platform across, so many different areas, including AI medical scribes and revenue cycle and so much more. So I appreciate you taking time to talk with me, and thanks everyone for watching and listening. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com or search for Healthcare IT Today on your favorite podcasting applications. Thanks, Sachin.
Thank you so much, John. I look forward to comparing notes with you in the future.